Hi docs, this is Dr. Yasmin from Royal Doc Line. I welcome you all, and today we will be discussing birth after previous caesarean birth, which in the guideline is mentioned as VBAC. The layout will be introduction, where the two options are given to the woman, either the elective caesarean or the vaginal birth, but it should be done with the provision of an evidence-based information. Second part will be the antenatal care, and here the suitability of the patient for the vaginal birth after the caesarean section will be including the counseling, documentation in the notes and the attached checklist. Then will be the intrapartum management of the planned VBAC, planning and conducting the elective repeat caesarean section, and how should the woman in a special circumstances be cared for. Summary will be given in the end. This is the Appendix 3 about the clinical management of the pregnant women who have had one or more caesarean births. As you can see, the first thing is rule out any contraindication to VBAC, which is placenta localization, and review the previous record and operative notes, medical or obstetrical condition which can preclude the VBAC. Explain her about the risk and benefit of both the options. For example, the woman with the previous vaginal birth, they should be informed that the previous vaginal delivery, particularly the previous VBAC, is the single most predictor for the successful vaginal birth, and it is associated with the planned VBAC success rate of about 85 to 90%. Greater maternal height, maternal age less than 40 years, BMI less than 30, and the gestational age of less than 40 weeks with the birth weight of the fetus less than 4 kg, all of them, they are associated with increasing likelihood of successful VBAC. In addition, if the patient has got a spontaneous onset of the labors, vertex presentation, and the head is engaged or the head is at a lower station, and higher admission Bishop score is also associated with the likelihood of the successful VBAC. Successful VBAC is more likely among the women with the prior caesarean for fetal malpresentation, which is about 84%. Always involve the patient in the decision making and please take into account her future reproductive preferences. This one is about the likelihood of the VBAC and elective repeat caesarean section. These all incidences are very important from your exam point of view. Regarding uterine rupture in both the cases, VBAC and ERC, blood transfusion, endometritis, maternal mortality, and about the fetal newborn risks, which include transient respiratory morbidity, antepartum stillbirths beyond 39 weeks while awaiting the spontaneous birth, hypoxic ischemic encephalopathy. They should also be discussed with the woman, and please review all of these incidences before you go on for your exam. Intrapartum management of the planned VBAC. Women should be given the advice that the planned VBAC will be conducted in a suitably staffed and equipped delivery suite with continuous intrapartum fetal heart rate monitoring, and the resources should be available for immediate caesarean section along with the advanced neonatal resuscitation. Epidural can be given. However, if the patient is demanding increased epidural doses, then anticipate the uterine rupture. Continuous fetal heart rate monitoring by using the CTG. Continuous tachographic should also be done along with the continuous fetal heart rate monitoring. Anticipate the uterine rupture if you see any abnormal CTG, severe abdominal pain, acute onset of the scar tenderness, abnormal vaginal bleeding, hematuria, cessation of the previously efficient uterine activities, maternal tachycardia, signs of the shock, loss of the station, or change in the abdominal contour, or you are unable to pick up the fetal heart rate at the older transducer site. Planning and conducting the elective repeat caesarean section should be at 39 weeks of the gestation. Antibiotics can be given as per NICE guideline. Thromboprophylaxis according to the RCOG guideline. If you think that the patient is having placenta previa, always take a multidisciplinary team approach. However, the women who are coming in some special circumstances, they should be cared of with a special way. For example, the induction of the labor by using the mechanical methods are associated with the low risk of the scar dehiscence and the scar rupture. Clinicians should be aware that there is uncertainty about the safety and efficacy of the planned VBAC in the pregnancies which are complicated by the post-date twin gestation, macrosomic fetuses, antepartum stillbirth, or if the maternal age is more than 40 years. Hence, a precautious approach is advised if the VBAC is being considered in such circumstances. And the people who are opting for the preterm delivery by the VBAC, they should be informed that the success rate is similar as with the term VBAC. However, there is a decreased chance of the uterine rupture in the preterm delivery. This is an important exam question. The summary and the key points are given here, which includes the selection of the patient by the counseling, checklist, shared decision, patient information, leaflets can be used. Rule out any contraindication. For example, previous uterine rupture, previous high vertical classical scars, and the previous 3 cesarean section. The success rate is about 72 to 76% if the patient has 1 previous cesarean, and 87 to 90% if she has given a previous VBAC. And if the patient has got the previous 2 cesarean section, then the success rate is 71.1%. Uterine rupture in unscarred uterus is 0.5 to 2 per 10,000, and in 1 cesarean section, it is about 22 to 74 over 10,000. With the 2 cesarean, it is 1.36%. Maternal mortality from the uterine rupture in the planned VBAC is less than 1 over 100,000. And however, if the delivery interval between the previous cesarean and this time delivery is less than 1 to 2 years, there is 2 to 3-fold increased risk of the uterine rupture. Similarly, inform the woman that if she has got an induction or augmentation, there is increased chance which is about 2 to 3-fold risk of uterine rupture and 1.5-fold increased chance for emergency cesarean section. However, attempting the VBAC reduces the risk that the baby will have respiratory problems with the VBAC, which is about 2 to 3% against the elective repeat cesarean section, which is 3 to 4%. You can memorize it as 2, 3, and 4. So let's see the original guideline. Here you can see the executive summary is given, which I have marked all. And similarly, I have marked all the important points in this guideline. Thank you. Have a nice one.